Hello, everyone. Welcome back to Pulm PEEPs. Really excited to be here today. Great new content. You can probably see we're doing some new stuff with some video, some audio, some new infographics, and working really well with our team. Furf, always great to see you. How's it going today?
It's good. Like you said, it's expanding. We're very late to the video party. Obviously, we're not the first to discover meta videos, but we're excited to be expanding into these different areas. And we hope you guys are enjoying the content. Let us know what you think. And we have another great episode for you today.
Today, we're talking about what may seem like a simple but really high-stakes ICU decision. And that is, how do you run your spontaneous breathing trial, or SBT? So let's set the stage real quick. We're all in the MICU, day 4 ventilation for one of our patients who was admitted with pneumonia and septic shock. Fortunately, now off pressors, awake, following commands. Sedation's been stopped in the morning, and we're on rounds, and our bedside nurse asked us, can we do an SBT this morning? And RT's there and wants to know, sure, but what are we doing? 5/5, CPAP, T-piece. So today this is going to be Furf's Pearls on spontaneous breathing trial methods and how to pick between them. Okay, Furf, so I know I'm interested to hear your thoughts, but before we dive deeper into a little bit of the modes, what is an SBT really supposed to be doing?
Yeah, absolutely. This is one really interesting topic. I love that we're setting the stage talking about a patient. In reality, hopefully that conversation you're having about SBTs is at a higher level, and SBTs are automated in most MICUs now, where there's a screening checklist and the RTs know exactly what to do. The nurses like to check and make sure the patient's ready. And this is done at 4 or 5 or 6 in the morning. And by time rounds is there, you already have the results. But this is exactly the conversation we have at sort of the high level about what kind of SBT do we want to do. And then sometimes at the patient level, if they have certain dynamics going on. So what is an SBT at its core? This is a spontaneous breathing trial. It's basically a stress test for life after the tube comes out, after extubation. And what we're trying to predict is to see if the patient can handle the work of breathing that they're going to face post-extubation. They obviously needed the breathing tube for some reason. Just being on the breathing machine and being sick can cause certain level of pulmonary dysfunction, certain level of muscular weakness. And so we don't know exactly what they're going to look like when they're coming out of it. And we want to be able to predict if they're going to succeed after extubation. So the tricky part is that when we set up the trial, we can overestimate what that work is going to be like. In some ways, this is like thinking about the sensitivity and specificity of a test. We want to be able to do a test that tells us what they're going to look like afterwards, but we can't be too strict. We can't be too lenient. So a T-piece, for example, essentially just puts oxygen through the endotracheal tube and gives no inspiratory help. There's no pressure. There's no volume delivered there. The patient takes on pretty much the full work of breathing, plus the resistance through the tube, which is not sort of a natural state to be breathing in. And this might be a little too stressful for people. So we might end up extubating fewer patients, and then we're missing the point. Our whole goal is to be extubating some people. And you'll hear in every ICU across the country, if you're not failing some extubations, you're not extubating enough people. So we know that we can't be too strict about it. On the other hand, we have some modes of spontaneous breathing trial that give people help, both at a sort of a rest with breathing, just some PEEP, and some pressure support over when they're taking a breath. So pressure support 5/5, sort of designed to offset the resistance of the tube at all times. You always have that 5 of PEEP. And then you also get in the little extra 5 with the breath, and physiologic studies that suggest that while this is going to have more people pass SBTs, it may be a little more help than they would have post-extubation. It might not mimic that post-extubation circumstance perfectly. And so that might not be predictive enough to know if a patient is going to pass their extubation attempt. And then there's CPAP. You could do a 0/5 where you might land in between these. So our goal is really to extubate people. We want to not be too strict about this, but we also want to make sure that once they're extubated, they have a reasonable chance of success. And so we have different studies and different methods for doing this, and that's what we're trying to decide on today.
Thanks, Furf. That was such a great overview. And I think many of us, and this could be, patient, it's obviously patient-driven, patient-specific, but some institution-specific as well. And I think most of us probably default to a 30-minute SBT on pressure support, 5 to 8 with a PEEP of 5. So that 5/5 or 8/5. But FERF, is that just habit, or what does the evidence really say when you compare that to a T-piece?
Yeah, that's a great question. So in this specific question of SBTs, of pressure support over TPs, we actually have some pretty good data. There's a large network meta-analysis of over 40 randomized controlled trials, has about 6,000 patients, that found that pressure-supported SBTs are more likely to lead to successful extubation than TPs, with about a 7% absolute increase and no higher reintubation rates. So basically, these are patients that would fail on TPs, but pass on pressure support 5/5 or 8/5, and then actually do fine when you extubate them. So that's good. We want to extubate more people, as we said. And that's just not a one-off. As we said, that's a meta-analysis. There's also some specific well-conducted trials. The FAST trial in JAMA compared a short pressure-supported SBT to a longer T-piece and saw higher extubation success with pressure support as well. Patients tended to pass their at first SBT sooner on pressure support than on TPs. And so you're not just getting them more extubation success, but you're getting them off the vent earlier. That's minimizing risks for ventilator-associated pneumonias and other things that we know can happen with the endotracheal tube. So for the average hemodynamically stable patient with straightforward respiratory failure, a 30-minute 5/5 SBT isn't just what we all do. It's pretty backed by data. There's a reason that is a standard in many places.
Yeah, for such a kind of great review of some landmark literature in this area. You brought up a great method, which is the T-piece, right? You said it's a little bit harder test. Sometimes people will also equate that to, someone breathing through a very narrow straw. But for certain patients, it makes sense to do this. Right. So we can say, for some patients, pressure support 5/5, that looks great on paper. But we all know that some people still need to go to T-piece for this. So when does a T-piece actually make sense?
Yeah. So there's definitely still a role, and it's useful to understand this test so you have it in your armory if you need to do it. So basically, a T-piece gives zero inspiratory assistance and zero PEEP. It's not helping you when you're in your exhalation stage. It's not helping you in your inspiration stage. Physiologic studies show that this produces higher work of breathing and is probably closer to post-extubation effort than 5/5. 5/5 is a little unnatural. And so you're less likely to get a false positive SBT when you're doing a T-piece trial, where you take it out and the patient really just does poorly. If they've passed on T-piece, pretty likely that they're going to do well post-extubation. So it's really useful in a few circumstances. It's very useful when the cost of reintubation is high or your pretest probability of success is low. And in addition to those two, it's also really helpful when what might be helping the patient is really the even small amount of positive pressure having an outsized impact on their work of breathing. The classic example of that is someone who has significant LV dysfunction and pulmonary edema, where they really, even just 5 of positive pressure is helping drive some of that pulmonary edema back into the capillaries. It's also decreasing wall stress and decreasing afterload on the left ventricle and helping left ventricular performance. And so it's not so much all the other help that they get for the ventilator. It's not so much that they have a set respiratory time. It's not so much that they're getting huge tidal volume assistance, but just that little amount of positive pressure. And so you really want to mimic what that's going to be like before you take an extubation trial. So that's one subpopulation. It's really helpful to do a T-piece trial. But going back to the first two things I said too, where you have cost of reintubation or a high pretest, or your pretest probability of success is low, if you have somebody who has a tenuous airway, say they were a difficult intubation in the first time, and extubating them is a little riskier, a little more difficult, you might want to think about making sure that your SBT has a high chance of predicting success. And so you might think about a T-piece trial in that patient. Another population, you might want to say that you were going to do a little bit harder of an SBT is like somebody who's been a little bit difficult to wean. Maybe you're just not sure that they're ready. You're trying to decide between trach and an extubation trial. Maybe they failed an extubation already. And so you want to just have a little more assurance that your SBT is going to predict success. You might say, let's make this a little bit harder on them. There is a group of people who would say not to do that, to say you want to give them a shot of passing. And so just do a traditional SBT. And if they do well, give them another shot of extubation. But if you're really concerned and you're sort of saying, I just need a better predictive tool, I really want to know if they're going to pass this time, a T-piece might be the best way to go. Some protocols in these higher risk groups will even use a hybrid approach. They'll do a pressure supported SBT and see if they pass, and then follow with a shorter T-piece as a confirmatory test just before they pull the tube, like not a full 30 minutes. So you have to think about what is best for your institution and what's best for the patient in front of you. But it's good to know that you have these options when you're trying to decide for a patient.
Thanks for walking us through that. Right. And I think so important. I think quickly, I know for T-piece, right, for certain patients, definitely appropriate for the patients that you said with pulmonary edema, LV dysfunction. I think an important thing is like talking with the patients as well, right? Like this may feel slightly uncomfortable, but this is why. Don't be alarmed. And then this is one where I think if you and I aren't in the room watching the patient on the T-piece, we definitely have someone on the team in the room looking at that. So thanks for walking us through that, Firth. And I think probably one more area to go before we end today is what about just, straight CPAP? Is there a reason, to go to CPAP instead of pressure support 5/5 or T-piece?
Yeah, absolutely. So the rationale behind this, CPAP would be 0/5 on the ventilator and a pressure support mode. The rationale for this is that you want to be in the middle ground between T-piece and a full pressure support mode. You want to have the patient do their full respiratory effort on their own to see if they can do well after extubation. But we acknowledge that the endotracheal tube adds extra resistance to the respiratory system. And so that CP per 0/5, that 5 that's there all the time, is sort of meant to counteract the extra resistance that just the 2 adds, and maybe it looks a little closer to what their breathing will be like afterwards. So the idea is that this is between a middle ground between these two. We have far fewer and smaller trials for CPAP than we have for pressure support versus T-piece. Some studies suggest that CPAP can help, like as a tube compensation, can bump up the SBT and extubation success rate a bit compared to pressure support alone. But the certainty is low, and there's no clear signal for better mortality or shorter length of stay. If you zoom out across all these modes, pressure support with PEEP, T-piece, CPAP, and even high flow through the endotracheal tube, which is sort of like a new mode that's coming up, the meta-analyses don't find consistent differences in mortality, ICU or hospital length of stay, or reintubation, except for some promising lower reintubation rates with high flow compared with T-piece and pressure support. So maybe some more data to come out there. So this probably tells us the magic is not so much in the mode itself. It's in adjusting to the patient you have in front of you and making sure that you have a systematic way of doing SBTs every day and seeing if patients are ready for extubation. So the pragmatic take is you can use 5/5 as an efficient default for most patients. If you want a harder test, you can use a test like T-piece when you really want to avoid a false positive SBT or when the physiology makes sense for it, like LV dysfunction. We can consider CPAP or something like CPAP with an automatic tube compensation in specific situations or based on institutional protocols, if that makes you more comfortable. But know that there's no data out there that when we apply it to all patients that this is a better mode. And we just remember that a standardized at least once daily, but usually once daily screening plus good bedside judgment probably matter more than any single perfect SBT recipe.
Great pragmatic approach for us to be able to take away from today. Maybe last question. Are there any situations besides the ones that you just talked about where you may do something different?
Yeah. So I just want to point out that, again, this is all based on your expertise and what your institution is and the patients you have in front of you. So there are times when things might be different. So for example, in some surgical ICUs I've worked at, they've done pressure support on 10/5. Basically, they've said these patients had healthy lungs going into surgery. Maybe their surgery was not one that we would anticipate major respiratory complications, except for the duration of intubation. And they've sort of said, we really want to have a very low threshold. We think these people should do fine. A lot of anesthesia cases, they extubate right afterwards. And so if they haven't done that, they brought them to a surgical ICU for whatever reason, they may be more liberal. And so they'll do a pressure word 10/5 and get the tube out earlier. Also, there are places I've worked at who've done 5/0. They've sort of said, we don't really care about compensating for that dead space of the tube or the resistance of the tube, but we want to give them a little bit more resistance. We want to be between the difficulty of full pressure support and TPs. And all that does is shift your sensitivity and specificity a little bit. And so you just have to think about what those different settings are telling you about the patient. So just to mention, you may work in places that do something different from this, and you just have to stop and think to yourself, okay, what does success in this type of SBT tell me? What does failure in this type of SBT tell me in terms of their negative and positive predictive value?
Awesome, Furf. Well, this has been such a fun discussion with you already this morning. In our last minute or so together, can you break us down even more first for Pulm PEEPs Pearls for SBT methods?
Yeah, absolutely. So Pearl 1, an SBT is a stress test of post-extubation work of breathing. TPs tends to be the most difficult. 5/5 tends to be the standard, a little bit less difficult to pass. And CPAP sort of lands in the in-between between those two different modes. Pearl number 2 is that for the typical ICU patient, a 30-minute 5/5 SBT leads to slightly higher extubation success and earlier SBT passage than a TPs without higher reintubation or mortality. Pearl 3 is that TPs can still be valuable when you want a tougher test. You have difficult to wean patients, you want to be very sure, you have a high risk airway, or if TPs helps mimic post-extubation physiology most accurately, like patient who has cardiac dysfunction. Pearl 4 is that CPAP and CPAP with automatic tube compensation are reasonable options, but have thinner data. There's also other options out there, like we talked about, different modes. And across modes, it's not clear that one is greatly superior than another in these combinations. But the most important thing is that protocolized once daily screening, bedside judgment, and making sure you're doing SBTs helps patients get off the ventilator faster.
Awesome. Well, couldn't have picked a better topic to talk about today with you, Furf. Had such a great time.
Yeah, this was awesome. We'll thank you all for listening, and we'll see you next time. This script was helped by George Doumat. He is one of our associate editors, and edited and produced by myself and Christina Montemayor, and music's originally by Eric Rodgers. Thanks for listening.